Hello, my name is Rod Taylor. I'm a Professor of Population Health Research based at the University of Glasgow, and it's my pleasure and privilege as one of the co-lead investigators to talk to you about the Across collaboration today. So what is the Across collaboration? Well, the acronym stands for Affordable Cardiac Rehabilitation and Outreach Interdisciplinary Strategy Study. And this is our vision. Whilst it is short, it is ambitious, ensuring global access to affordable and effective rehabilitation for people with heart disease to enable them to lead longer, healthier, and more productive lives. And leveraging on the back of the WHO strategy document, we would have an ambition to make rehabilitation a universal coverage intervention by 2023. I'm delighted to say that the Across collaboration has a number of partners, not only ourselves in United Kingdom, that is University of Glasgow and University of Manchester, together with colleagues from Leicester University, but we also are very fortunate to have three very strong low and middle income country partners in India, Bangladesh and Pakistan. And as you can see summarized from this figure, each of these countries have a number of clinical centres that they are linked to, who we will be participating with in the Across project going forward. And last but not least, again, we are very fortunate that we are under the support of an international advisory committee that includes colleagues from Canada, Australia, and Denmark. So a truly international collaboration. So why Across? Well, if I begin, first of all, in terms of consideration of cardiovascular disease, I'm sure as many of you will be aware, cardiovascular disease is probably the single leading cause of disability and death worldwide, especially in low and middle income countries. And here are some statistics for you. Not only is that major cause of death, but a major cause of what we would call Daly's disability life years. And indeed, if we look forward, by 2023, it's anticipated that at least 4/5 of all CHD mortality and morbidity will occur in the low and middle income country setting due to the explosion in risk factors such as hypertension, smoking, etc. And of course, as part of the cardiovascular diseases, heart disease in particular is a major contributor to the burden. If that wasn't enough, the burden of heart disease and cardiovascular disease is also further exacerbated by the global prevalence of multimorbidity, especially mental health. And indeed, as I will show you in the next slide, there's a double lock between mental health and heart disease. What do I mean by that? Well, as this slide shows you, conditions such as anxiety and depression are not only risk factors for the development of heart disease and other cardiovascular diseases, but also if you have a co-incidence of depression or anxiety alongside your cardiovascular disease, it markedly increases your risk of reduced quality of life, morbidity, and mortality. Now, alongside this, one of the other key aspects that we need to talk about in the Across programme is the very strong evidence that we have that rehabilitation is an effective intervention for people who have cardiovascular disease, and indeed alongside a mental health condition. And this is just one piece of guidance that comes from the European setting where I am based, showing that we actually have very high quality evidence that rehabilitation, class 1, level A evidence, is effective in reducing the risk of death and improving quality of life. Um, but in spite of a number of innovations very pleasingly happening in low and middle income countries, particularly aspects of diagnostics and therapeutic procedures such as percutaneous interventions, the provision of evidence-based secondary preventative strategies for cardiovascular disease and mental health is sadly lacking, alarmingly behind. And indeed, just to give you a feel for this, the International Cardiovascular and Prevention Rehabilitation Group did a survey in 2013, and just as an example, in Bangladesh, there is only one program for people with heart disease in terms of their rehabilitation, in spite a level of incidence of coronary heart disease that exceeds that in, for instance, England, where we have over or around 500 cardiac rehabilitation programs. And as I say, meta-analyses of randomized controlled trials of rehabilitation have shown strong evidence, but sadly, the majority of that evidence has been undertaken in high-income country settings, and of course raises the question of whether we can generalize that evidence to low and middle-income countries, given the important differences in culture, in context in those settings. And just to illustrate this further, this is the ICCPR survey again. This is a global map where the areas in grey and red show you the areas with very poor or low provision of rehabilitation for people with heart disease. And you can see that this certainly includes our South Asian colleagues of India, Bangladesh and Pakistan. And indeed, this is in sharp contrast to this map that shows you the incidence of coronary heart disease. So you can see that despite the fact that we have some of the countries in the world with the highest incidence of ischemic heart disease, such as South Asia, we have this paradox of very poor, if not negligible, access to rehabilitation. And this is obviously something that we in the Across programme wish to attend to. So what is the Across project and what are we aiming to do? Well, at the moment, we are just in the middle of what's called the National Institute for Health Research Write 3 global competition. And this is a specific competition where the Across project has been shortlisted alongside other projects to look at the issue of providing services for people with multimorbidity. So the specific aims of Across in this context are to co-develop and evaluate a culturally and contextually adapted model of rehabilitation, which we call Across, that would be affordable and scalable for people with multimorbidity. And importantly, in this context, that includes people with heart disease and also a mental health condition that can be implemented not only in low and middle income countries, but globally, because sadly, although we might have a goodly number of cardiac rehabilitation programs in high income country settings, access still remains poor. So the specific question, research question we wish to achieve is this following, is the addition of the culturally and contextually adapted home-based program to usual care for patients with coronary heart disease or heart failure with depression or anxiety clinically effective and cost effective in the settings of Bangladesh, India and Pakistan. So what is it we exactly propose to do in our research? Well, our programme is divided into 4 work packages, or WPs as abbreviated here. So WP1 is to first of all culturally and contextually adapt and refine existing home-based rehabilitation interventions. Those interventions being interventions that we've developed in the high-income country setting, including the Heart Manual and REACH-HF, together with low-intensity interventions targeting depression and anxiety. After that first 12 months, we will then undertake an external pilot trial in each of our 3 countries, 2 centres in each country, recruiting 100 patients per country. And the purpose of this external pilot is to test the acceptability and feasibility of the intervention, but also a proposed randomised controlled design. And then in the last few months of the programme, we wish to undertake a fully powered, multi-centre, multi-country randomised control trial to fully estimate clinical and cost effectiveness that will include 1,000 patients per country, where the primary outcome is a composite of mortality, hospitalisation and quality of life. And then running alongside all of these 3 work packages is a programme of capacity and training development to develop bilateral research and rehabilitation delivery capacity, and that will include 9 PhD students, 3 in each of our ELMIC country partners. So this is a busy slide, but this is just to give you a feel for the evidence base that we have for the REACH-HF intervention, the top 3 screen grabs, and the Heart Manual, the bottom 3 screen grabs, all been evaluated by randomised control trials, been also shown to be cost effective, but as I said earlier, that evidence has been limited to high income country settings. So we want to take and adapt these interventions to our 3 low income countries. This is the consort flow diagram for our planned trial, and you can see we will screen people with multimorbidity that includes coronary heart disease, heart failure and depression and anxiety. Then those individuals who are deemed suitable will then be randomised to receive the across intervention plus usual care or usual care alone. And then we will follow those individuals up for 12 months for the primary outcome and a number of secondary outcomes, including their mental health. So I'm going to finish up there by just talking through the timings of the programme. The programme is, if it's funded, which we hope it will start in July 2024. This is the timeline you can see for the 3 empirical work packages, together with work package 4 that runs along in parallel over the 60 months. So in conclusion, I hope you find this presentation useful. If you would like any further details of the Across collaboration, please do see our website or feel free to drop me an email. This is my email address. Thank you again.